So, Dr. Gorgun is the vice chair of the Department of Colorectal Surgery at the Cleveland Clinic. He earned his medical degree and completed general surgery training at Istanbul University before moving to the US for research and clinical fellowships at the Cleveland Clinic. He subsequently completed advanced laparoscopic and colorectal surgery training at New York Presbyterian, Weill Cornell, and Memorial Sloan Kettering, followed by an executive MBA from Case Western. A leader in minimally invasive, robotic, and endoluminal surgery, Dr. Gorgun has developed and directed major programs both within Cleveland Clinic and nationally. His clinical interests include endoluminal surgery, minimally invasive and robotic colorectal surgery, rectal cancer, and IBD. He is active in numerous professional societies and has authored over 300 peer-reviewed publications, along with multiple book chapters and invited lectures. He's married and the proud father of two children. Outside of work, he enjoys sailing, skiing, and traveling. So, Dr. Gorgun, I will hand it over to you.
Thank you, Katie. Really appreciate it to be talking to you all tonight, Sunday night, later afternoon. I hope everyone had a great weekend. And thank you for the kind introduction. Very, very nicely presented. I will be presenting on techniques in advanced endoscopy or advanced polypectomy techniques, specifically in colorectal surgery tonight. So why advanced endoscopy? Why advanced polypectomy techniques? And why do we really, as surgeons, need to be facile and trained in this area, and also ESD, endoscopic submucosal dissection, or even a broader term, endoluminal surgery? And I love this term, ELS, or endoluminal surgery, because we are surgeons, and I think this is heading into that direction. It's not just EMR, endoscopic mucosal resection, or endoscopic submucosal dissection, but it is really endoluminal surgery. So within the lumen, we can do a large number of procedures now, and we can really use even retraction tools and dissection tools, cutting, and even suture within the lumen. So really the term endoluminal surgery resonates much more than just ESD or EMR in the colon. So next half an hour or so, we'll be talking about these various techniques, and as surgeons or even as advanced endoscopists, what we can accomplish. But before getting into the details of these techniques, I think we need to also understand why we need to get really good at this. What is the needs assessment? What is the reason that we really need to get good at this? Well, this is now earlier data, earlier population-based study, but in this data that it is shown that in the United States, large number of colon resections are performed for benign polyps. So, and this is calculated to be 30,000. So this is really a large number. And you can think that just doing a polyp removal or just doing a colon resection, simple right or left, we can successfully treat our patients. But we also know that many times patients have a lot of complications after surgery, morbidities. The morbidities can be up to 35%. And also we know that mortality, even for colon resection done for benign reasons, for polypectomies, for polyp resections, we know that in the data, this is up to 1%. So out of 100 patients, one person may die, according to the nationwide data, and that's preventable. How is it preventable? Just getting facile in these colon resection, polyp resections endoluminally. But before you start to do these procedures, of course, you need to know your tools. You need to do, especially if you're going to use endoscopes or colonoscopes, you need to just really understand the tool, the device that we're using. Exactly like you know your laparoscopic graspers, you know your telescope or your laparoscopic camera. You need to know how to operate it. And most of us don't really look even at the tip of our scopes. We just grab the handle and try and start to move around. But really, before you need to, when you have a chance, don't turn the light on, but just look at the tip. Look at the different items within the tip. Where is the lens located? Where is the therapeutic channel located? What are the outlets for cleaning the lens? Where's the outlet where you really have a water jet coming out? So you can understand these. That can help you to be better when you do these. Even diagnostic colonoscopy, you can get better at it. And you can then position your lens according where the lesion is. And you're gonna know if you're gonna inject, for example, where that tip of the injection needle will come out. And you will also know that that therapeutic channel actually is the same channel as suction catheter or where the suctioning will be going through. And if you're going to understand that if you have a tool in the therapeutic channel, that's going to interfere with your suctioning. Or if you did do a piecemeal EMR, the pieces will not come through if you have still the snare in the channel. So these things will be more clear to you if you know your tool. You also need to know your different snares, for example, if you want to do even a simple polypectomy. Most of us, or most of the even some of the surgeons, surgeon endoscopists, they just ask for snare. I think that's really almost like asking for a suture. I want a suture. We say 2O, 3O vicryl, right? Or PDS. So we are more specific in the tools or what we are asking for to our scrub techs. And it's the same thing with the advanced endoscopy or even regular endoscopy. You can't really ask for snare. You need to say what type of a snare you want. Do you want a 10 millimeter snare? Do you want 15 millimeter snare? Do you want 20 millimeter snare? What size? Do you want oval or do you want round? Do you want braided? Captivator, even with specific names, lariat, different names exist. Do you want cold or hot? These are all important items that you need to know. Again, that way you can, depending on the lesion size, lesions positioning and morphology, you might really ask for different type of snare. So you need to be familiar with that. Then it becomes, I'm not going to spend time with regular polypectomy, but we can start talking about EMR, which really means submucosal injection first, followed by removing, resecting the tissue with multiple bites of snare uh, movements and snare closures. So in EMR, you don't need to take this lesion completely in one piece or what we call en bloc, but you can really fragment this and remove it. If you think that the lesion is benign, and most likely 99.9% is going to come back as a tubular or tubulovillous adenoma, I don't think there's anything wrong to do this type of a lesion with EMR technique, and that's totally fine. Here we are doing this injection technique, and as you have seen, the center did not necessarily lift uh, perfectly well, so you can go through the middle of the lesion and snare that as well. Here, this is one of my earlier polypectomy EMR techniques, and here I'm using a lariat snare, which is much larger, but nowadays I even use snare tip and pre-cut EMR, so cut with the tip a little bit around the lesion. Here, as you have seen, this is piecemeal, and the center did not necessarily is completely grabbed within the bites of the snare. So here you can do multiple bites and remove the entire area. But again, for EMR, usually it's good for lesions less than 2 centimeters, but you can do for lesions larger than that as well. And submucosal injection followed by multiple bites of snare resection is the technique. With that, actually, for a carpeted lesion, for example, even if it's larger than 2 centimeters, you can get this entire mucosal area resected. So hence the name MR, mucosal resection. So endoscopic mucosal resection. Even you can do a circumferential, completely 360 degrees of the circumference resect. by this technique, then, which is totally fine if the lesion is completely benign. But if there is any concerns that this lesion might be malignant or may have even high-grade dysplasia or some adverse features pathologically, and if you have any suspicion as such, then probably you'll be better off performing an ESD, which is an endoscopic submucosal dissection. And the technique entails typically marking the lesion first, as you see here on this picture on the left, by the mucosal markings by cautery, followed by submucosal injection. And I want you to pay attention to that clear cap, which is the distal disposable cap, clear cap, and that really helps us during the dissection portion. And after the injection, as seen in the picture B, then we move on to that C, which depicts the process of mucosal incision. So you cut the lesion, you cut the mucosa, and that's mucosal incision, followed by cutting the submucosal fibers. And exactly in this stage, the distal cap, the clear cap, plays a significant role, because then cap allows us to get under the pocket, under the polyp, and then it allows us to kind of create a traction, because as you can imagine, in the endoscopy world, we don't have a second arm to retract, which nowadays we use some tools, which I will talk about that a little bit as well later. But CAP really enables us, if in the lack of these additional tools, to do the dissection more easily. And then we retrieve the lesion and check for hemostasis and complete the process. It was initially introduced in Japan, as in Japan, the gastric cancer is very common, and a lot of patients from eating pickles, uncooked vegetables, raw food, the gastric cancer was very common, and in the early cancer was treatable with just endoscopic removal, and plus this resecting gastrectomy is a very high morbid operation, a lot of quality of life issues. So physicians didn't want to do that, and they just did the ESD, developed the ESD techniques. Subsequently, these techniques were expanded to the colon, and we nowadays do extensive amount of ESD in the colon as well. And here you see in the middle in the video clip mucosal incision, and subsequently we get under the pocket, as I described in the previous slide, using the cap with the retraction and remove the lesion completely. So ESD can be taken to the next level by putting maybe additional tools like retraction. You can see that at the base of the slide on the right hand, and really take it to the next level, which is ESD, endoluminal surgery. But we can treat with ESD also early stage carcinomas, adenocarcinomas, mostly T1s, possibly in circumstances and high operative risk patients, maybe T2s as well, as long as there's no concern for lymph node metastases. And then, of course, we nowadays do also ESD even after TNT for patients after near complete response. And sometimes there's an adenoma left behind. And we recently published in DCR on that experience as well. So you can really remove these little luminal lesions or regrowths and with submucosal dissection, rather than just doing a full thickness removal. Again, if we can do these large lesions, even circumferential lesions with just EMR, which is probably easier, why to do ESD, right? You can ask yourself or ask me, why do we need to do? What's the benefit of doing these in ESD? This is a comparative study from Japan comparing EMR to ESD, and certainly, as it's highlighted here, the en bloc resection rate is much higher when you do EST versus EMR. Obviously, if the lesion is bigger, you're not going to be able to get the piece in one block, and that will lead to misinterpretation of the histopathology possibly, or as we always come across as surgeons in our offices, if someone comes in with invasive adenocarcinoma and margins cannot be assessed because of the polypectomy was done in a piecemeal fashion, or cancer present at the cauterized edge. So that's the worst thing because we can't then make a decision. However, if this lesion would have been taken out by ESD technique, and if the depth of the invasion would have been really low and the margin negative, this patient wouldn't need any further operation. Imagine the specific patient is a high morbid, high BMI, very poor operative risk. Why to put that patient to a really risky operation if you could avoid it? Additionally, the recurrence rates are much lower when you do EST as well, because when you do EMR, the snare might leave some adenoma tissue at the margins behind or even in the center potentially, and that can lead to recurrences in the follow-up period. Whereas with the ESD, you know that you completely cut the margins clearly, and you're not going to have a recurrence rate. On the other hand, you may think that there are higher perforation rates, and that's true. In this series, you can see that that's 6.2 versus 1.3, but in this series, it was not found to be significant. Interestingly enough, the late bleeding, if you look at that, EMR is higher, 3.1 versus EST, only 1.4. And the reason for that is when you do EMR, you kind of chop the perforating vessels off because you don't see them, you just blindly cut them. And usually it's a very fast cutting mode with the snare. It's not cold, but it is not very high duration energy application. So it can lead to like a temporary vasoconstriction followed by late bleeding. Versus when we do ESD, we see these every single vessel come across, and we purposefully coagulate them along the vessel length up and down, and then we have much better control for these. Certainly, ESD takes longer, but in expert hands, this dissection speed can go lower much faster. So we have a unique advantage as surgeons because you can start these advanced polypectomy techniques, EST techniques, and then protect yourself or bail yourself out if you have any complications. Let's say you perforated it, you are early in your learning curve, you're doing a polyp resection on the right colon or ascending colon or in the cecum, and then you have a perforation and you don't feel comfortable clipping that, you can really do laparoscopy and repair that hole with intracorporeal suturing. That provides you multiple advantages, not to mention that you can get facile with intracorporeal suturing even with laparoscopy, which many colorectal surgeons are not trained in that, but that's a great way of learning that. Plus, you can take care of your own complication immediately, and patients can go still home same day after this type of intervention. This is a real operating setup for that type of case. This is from many years ago, maybe 10 years ago, 15 years ago, when we first started. This is Dr. Maher Abbas, who was visiting us at that time, and this is me operating on the laparoscopic portion. And as you see, he's scoping from the bottom. So it's a two-person operation and assistance, obviously, for laparoscopy. You can see on the screen on the right that we are looking at the laparoscopic images, and he is scoping transanally in the hepatic flexure, which we did remove a large polyp and put clips in, but we are just doing a leak test to make sure. And there was a tiny air leakage that I end up putting a couple of sutures in this specific case. But this is the OR setup. I always leave the leg portion, even in lithotomy, put that up there, the leg extension up, so that helps you to support the scope during during colonoscopy procedure, because it's very difficult to do colonoscopy in a lithotomy position in general because it falls out. With this approach, combined endolaparoscopy, you can do many things. You can, if you have let's say a large polyp, we published this. This is an en bloc resection of a 5 centimeter flat ascending polyp. You can do cecal wedge resection. Or you can include even the appendix with that resection and still preserve ileocecal valve. And these patients recover really, really very quickly. Or if you, let's say, have a big polyp in the ascending colon, use the scope like a bougie underneath and put maybe some stay sutures, lift it up, and then just staple underneath the whole area if you're not even comfortable or putting a suture in. Or if it's a large defect, that might make things a little bit faster. But if you want, you can, of course, suture that as well all along. And nowadays, obviously, we have also the V-locks, braided sutures, barred sutures that can make things even easier. But as you get more facile, you can really tackle more difficult lesions. For example, this is a lesion that we did in the rectum. This is a circumferential rectal lesion, and this patient came to me from Mexico. She was monitored for a very long time because surgeons didn't know what to do, or endoscopies were not comfortable. You see, with the endoscope, you can really magnify and see everything very nicely. Here we see circumferential resection, and then this is a knife now that can also inject as you go, so it makes things much faster because you don't need to exchange a knife to injection needle here. And this is submucosal dissection. See, you can't do full thickness or TAMIS these cases. And this is a retraction device, a grasper that we put along the side of the scope, not through the therapeutic channel, along the side. You can do that in the rectum. As you go higher up, this might not be possible. But this is a large lesion removed in a tubular fashion, and the pathology came back as sessile-serrated, traditional sessile-serrated polyp. There was no cancer, and patient treated well. In other places, she was recommended to have major surgery, which we didn't have to do that. These are obviously long operations. Even the tip of the needle was melted away from the heat that we used, but you need to take your time and do these operations. Sometimes it takes 4 hours. So therefore, maybe we need tools that we can do retraction and take it to the next level, what we call like endoluminal surgery, and use some retraction devices. So dilumin is one of those tools. Here you can see a double balloon system that since then this is upgraded to a single lumen. But let's start with this double lumen, which had also 2 channels at the side. And there's a push rods that puts one of the 4 balloons further in, like more proximally, and you can do these complex resections. This is an example of such procedure. This was in the right colon. You're looking at the ileocecal valve on the bottom, and the polyp is sitting just next to that. You see this 4 balloon is placed, pushed with the push rods, and then from the side channel, the grasper is introduced into the colon. So right now, we are in the right colon with the grasper inside of the intestine. So we literally doing an endoluminal surgery because we have 2 hands that we can operate with. One, the endo knife that we can do the dissection, and then our other hand is the retraction. So we are literally performing an operation, surgery within the intestine. So this is I think, a true definition of an endoluminal surgery. You can even move the polyp or move the lesion from right to left and have full control of the lesion. And if you after you take this, then you move the lesion to the opposite side because that's our surgical principles that now we can bring the lesion completely to the opposite side, use our water jet, irrigate, get rid of the bleeding, and then cut the opposite side and completely remove this lesion in an en bloc fashion. This is a large lesion, 6-7 centimeters within right colon and completely removed. You see here 70-80% of the circumference, and this you are within the this outer tube, and then the entire lesion then is retrieved and pinned on a cork board as we always do. This is another similar approach, more scarred lesion. This was in the sigmoid colon. Same thing, the foreballoon is delivered with the push rods, and then there's an overtube, and again, there's a retraction comes in from one of the side channels, and then we are doing this dissection again. Here, this is a qua grasper that works for hemostasis perfectly well, and don't be fooled. This is not laparoscopic surgery, but it looks and feels like that because we can use some of these retraction tools very effectively. And this was, like I indicated, very scarred. We needed this type of robust retraction to be able to get this lesion removed, and we were able to do that. The grasper is put on a instrument mount, as you see here on the right side, but it's not two-handed operation. The dissection knife comes from the therapeutic channel, and we only use one grasper only because it was incredibly difficult and challenging to operate two-handed operations. So that's hopefully down the road we will get there, but we are not there yet from that technique standpoint. So we were able to use the Dilumen C2, and were able to, majority of the lesions were proximal to the splenic flexure. So you can really get across the colon pretty successfully. However, it was difficult, like I said, to do two-handed operations. Therefore, the company later on came up with this single channel, single balloon platform. And because we only could operate with one grasper, and the dissection was done pretty much through the therapeutic channel of the endoscope. And if you really can, even if you can just accomplish a retraction with a grasper, I think that's a great advantage and success. Indeed, this is a case we did with the C1 platform, the same product, with the Dilumen C1 this time. And you again observing here the submucosal injection, and then circumferential incision, mucosal incision with the dual knife, with pro-knife here. And after you do this complete circumferential dissection, then you pull the scope out, put the overtube, the C1 platform, and deliver it back to the right colon. And the grasper again comes in from the side channels. And here you see the beautiful retraction, the efficient retraction. And here really the operation becomes like a 10-minute procedure because you don't need to struggle with the cap. You can just, like obeying our regular surgical principles, get this completely dissection and resection very quickly. And again, in the right colon, you have full control of the lesion with the grasper. So using the C2, C1, we have done over 30, 40 cases. This is the initial 22 table, but these type of efforts for newer technologies, enabling technologies, is extremely important to be supported because that's the future for which would enable us to do endoluminal surgeries. But the goal is, of course, endorobots potentially. Is that the future? It may be, and I think it is. And now we have the SP technology, and the robotic or the single port Da Vinci technique. And can we use that in the colon? How far up can we go? Can we do the same operations or similar operations that we do with endoscope, which is endoscopic submucosal dissection? Can we replicate these operations with the robot? Yes, we have done for years robotic TEMIS, but do we really need to do a full thickness excision? So that's what we're going to talk next 5 minutes or so. We all know the benefits of the robot, and SP, similar to the XI, has the ability to provide three-dimensional view. Hence, there are two lenses at the tip of the camera, and the arms, different than the XI regular robotic platforms, have the ability to bend and to have an articulation more than just the wrist articulation, but also the elbow articulation, and that's an advantage in the rectum. So it's a newer approach to apply this single port technique transanally. And I started to utilize this as soon as the SP was in the market, which we were privileged to have that at our center, as one of the urologists was instrumental in helping this tool and developing this tool. And we had an early launch. And then I said, this is a great tool that we could potentially utilize in the colon rectum as well. And this is, you see how we dock the robot. We mostly do in the lithotomy position, and again we use the positive pressure insufflation. And first started with gel point, because that's how you introduce the robot. First, of course, started to do some cadaveric labs transabdominally and transanally. We did start to do some procedures. This is transabdominal, but then when I moved to transrectal, first thing I tried to do was, can I do ESD with this? And this is not even with injection. Without the injection, even the precision and dissection was so precise that you could just remove the mucosa perfectly. And then we started to do our first robotic cases. Of course, did some abdominal as well, but to date we have more than 150 transanal endorobotic cases. And cautery is available. Submucosal injection you can also do with the robot, and I will show you some videos how this can be done as well. Again, this is the in the clinical settings transanal docking. The robot comes from the left side. You see here OR setup, and port placements are as seen here. So this is the single port device with the gel port, gel point path platform. And we use also a remotely operating suction irrigator, which really helps because it's flexible and in the anus, and especially if you go up into the colon, with the straight suction device, probably wouldn't be able to get all the way up there. But this is probably one of the most important slides, because I like to reproduce the same type of operation that we have been doing with the colonoscope, with the flexible scopes, but using the robots, which is then not an ESD, but it is an endorobotic submucosal dissection. Hence, it is an ERSD. And we published on this as well. And I will show you that publication a little bit later for people who would be interested to read up on it. But you can inject also using regular injection needles by grabbing the tip. And I tell my wonderful OR team, scrub techs and OR nurses, to put a little silk tie at the end of that injection needle, so I can grab that. Sometimes here I'm grabbing from the shaft, but you can do it from the tip as well, and then inject the lesions underneath and create the same submucosal lifting, followed by dissection. And I use a spatula, which SP robot comes with.
In this video, we describe how to perform robotic.
So here, this is a video that shows us a clip that submucosal dissection. This was a 59-year-old gentleman. The lesion was about 9 to 10 centimeters from the anal verge. This is the suction irrigator tool. As you all know, gel point pad is introduced with a special techniques, followed by putting the obturator and then putting these stay sutures at the wings of the introducer, and then we make a little slit with a spatula, a scalpel on the gel, and this illustrates the placement of the air seal trocar. Suction irrigator goes down. Camera usually goes to the top. If the lesion is enterally, you can switch the location, and then usually a spatula on the right and Maryland on the left. Here you can see the submucosal injection for such a lesion. Again, this is not full thickness. This is not full thickness excision. This is submucosal injection and completely injecting and lifting the lesion up, followed by submucosal dissection. Here we don't take the full advantage because it's very distal, but as we go higher up, you will see that the arms bend more, articulate more from the elbows. Here submucosal vessels are seen, and you can see the muscle here tenting, but you're not taking the muscle, you're leaving the muscle behind. And all around submucosal dissection, and this is the suction irrigator if you get into the bleeding. So something like this, if you would do with endoscope, obviously your camera gets really smudged, the blood may clog up, and then it becomes really, really challenging. Whereas here, for sure, you have much more better control with the dissection speed, with hemostasis, with visualization. Here you can see, now you're gonna see how the articulation worked. Because now you have much more dexterity because we are higher up and we can take full advantage of arm bending. Again, muscle is left underneath and lesion completely removed. I'm just going fast forward here. And now, what about the defect area, right? This is not full thickness. This is submucosal dissection. However, it's not endoscopically done. It's with robot done, but the lesion specimen is the same and end block resection. So you don't have to close that defect. And this was 8 centimeter lesion with high-grade dysplasia, no cancer, patient treated successfully. Here, similarly, and another example of endorobotic submucosal dissection, very fast. Here we experimented with the scissors, and here I also experimented. This is more earlier in my experience with the hook, but spatula is much more fine tip, and I like the spatula. Here you can see the hook maneuver. Of course, you can also put sutures in, and I trialed that, and I still do sometimes when I really have to do full thickness for different reasons. I close it, but for a lesion like this, you don't need to. It's just a submucosal dissection, and this was the lesion here. Again, benign. Since then, now the company came up with their port, which is the bubble port, you can call it, because it looks like a bubble, but the official name, commercial name, is the access port. So nowadays you can use this port to dock the robot. The advantage of that is you can seat the robot much more further out from the anus. So that gives you that ability to articulate much more away from the anus. So even for distal lesions, you have much more dexterity. So you can take advantage of bending more. This is
to present you a video in the.
This is a comparison between these two techniques. So yeah, this is the port that I'm talking about. This inner ring, like a wound protector, goes inside. Let's spend some time here. And then this is folded over, and then this bubble is attached. Bubble is attached at the at the top of this. So this white goes to the other portion of the white, and then this is the short entry guide. All the arms go through that. So here, interestingly, this lesion was pretty close to the dentate line. You can appreciate the dentate line on the left. So by injecting, and this is the technique now I was talking about with the silk suture at the end earlier. So you can see that lesion is really pushed away from the distal end. And I want you to appreciate how fast the dissection is with this technique. And again, just submucosal dissection, and you can use the bipolar and take good control of all these submucosal perforating vessels that normally can really be very nuisance. And then you can deliver the specimen into the bubble and visualization, so you don't have to undock everything just to retrieve the specimen, and you can visualize it there. This is similarly another lesion. This was a little bit more scarred, so here I think we sutured it, but another example for submucosal injection. And this was a lesion that was more anteriorly located. And again, dissection, and you can in between inject as well, and completely removal of the lesion. And this was the lesion, more scarred lesion here. Both of these lesions were non-cancerous. And let's see what this one is.
Revolutionizing colonic lesion removal.
Yeah, so again, this is a very large lesion. And again, these dissections can be done very, very fast. Here we'll go. Larger lesion, ESD probably would take a couple hours, 3-4 hours easily. And you can see the dissection speed here. But again, this is a ERSD. The muscle is completely intact. You're not leaving any full thickness defects. You're not looking at the mesorectum or perforation if you are higher up, and you can do hemostasis. Large lesion, 8 centimeters. Go home same day with low complication rates. Specimen. Pinning the specimen, if you're gonna do advanced endoscopy, is crucial. So your pathologist then will like all these clear margins can be seen, and you need to ask for the histopathology images from that. And I want you to see here, you can see this basal membrane here, the muscle layer, the muscularis mucosa, and then this is the whole submucosal plane. So you still give them plenty of tissue material, and this cauterized edge is way down just above the muscle layer, muscularis propria layer, and you're not taking the muscle. We're not talking about intramuscular dissection. That's something that could be done too, but if a lesion is T1, it's only gonna be in the submucosal plane, and if that's the case, you probably will need organ resection down the road anyway. So doing these big polyps in a full thickness dissection, full thickness resection does not make sense. This is another lesion. These examples can be multiplied, but I want you to see the image quality perfect, and then these large lesions, and you don't need to suture these defects. Imagine if this would have been sutured, you could create an hourglass appearance, or narrow the rectum. You don't want to do that as well. So this is our early experience with endorobotic submucosal dissection, or ERSD, published with our colleagues and our research fellows who have done terrific job putting this together. And now we recently expanded this to more cases and submitted for an update. So hopefully that will be published soon. However, this is our early with the first 90 patients, like I indicated. Now we have more than 150, but we had lesions up to 18, even more recently up to 25 centimeters. The en bloc resection rate is significant, 97%. So even in the best hands in Japan, en bloc resection rates are around, we have seen that comparative study, EMR versus ESD, is around 80, 84. This is way higher than that. And specimen size and distance from the anus can be higher up as well, 18, even there were cases that were able to go all the way up to 25 centimeters. So this is endorobotic techniques. Pathology mainly benign, but some patients we had cancer, 13% or so. Some of these because you're doing this nice specimens with en bloc, clear margins, and if it's T1, no adverse histopathological features like lymphovascular invasion, poor differentiation. You can really monitor these patients. You don't have to do organ resections or proctectomy down the road, unless these features are not there. Poor tumor budding, poor differentiation, lymphovascular invasion present, then of course these patients might need full thickness organ resection. However, even then, your surgery will be much easier because you did not violate the TME plane. So that's another advantage. If you would have done that with full thickness excision, your pathology would have been also unfavorable and you would need organ resections, then your surgery would be really extremely challenging. This is another case that was circumferential, and the MRI did actually show for this one a T3N0, but the pathologist did not confirm it. Look at this here, T3N0, very large tumor, but the pathology did not show that. And then we also didn't think that is cancerous by its endoscopic view, but the patient was recommended to have APR in different places. The lesion was starting right at the anal verge or dentate line almost. Therefore, there was even not a room to place the platform. So we started out with our ESD technique with the endoscope, cleared the anal canal circumferentially so we can park our gel point at the time the access port wasn't available, and we could dock the robot. But before doing that, as you have seen, we created that space in the anal canal completely, and then accomplishing that clearance, then we dock the robot here, and then followed by endorobotic dissection circumferentially. Obviously, this took us a little bit longer, but not that long, and then completely remove the specimen. There was a little defect, not all around, just at the left lateral aspect, and we sutured that closed. And this, you can see the specimen here in a tube fashion, about 15 centimeters long, completely removed this lesion. And the pathology for this was also traditional sessile serrated adenoma, even though the MRI indicated that this is T3N0. So that's another aspect. A lot of times your MRI will overstage. So if you don't have a positive biopsy for cancer, and if your endoscopic assessment makes you think that might be benign, it's worthwhile to do these operations. So this is completely removed, and this is the specimen. It was a traditional serrated adenoma with no signs of cancer. So yeah, this is an endorobotic approach, but there are nowadays newer endorobots, Endomaster Ease. This is, I believe, from Singapore. A physician is trying. We know EndoQuest from Boston now. They used to be in Houston, and they are doing a multi-center study. We are part of the centers for this multi-center trial. So they are up and coming, these endorobots, and we will see more and more. So that's the future. But as surgeons, we should be in this game, in this field, and hence we founded our endoluminal surgery center. I'm not saying, you should just dominate the field by yourself only or as surgeons. You need to collaborate. And that's Dr. Bhatt, my colleagues from GI. He does mostly upper GI and stomach EST, and I'm doing lower GI. And since then, we have trained some of my partners as well, Dr. Josh Samovilla, as well as Dr. Duraes Leonardo. And so we are doing more and more of these. And you see, when I first started 2011, we obviously you are one person, but after I started to train my partners, you can see this is the case numbers multiplied, and that's the power of building teams. We just recently held our endoluminal surgery conference symposium, endoscopic submucosal dissection symposium, as well as endorobotic symposium, which we believe that that's the future. And this was the second time that multi institutional and many countries were involved during this conference, and hopefully we will do our third year as well. So in conclusion, endoluminal surgery is not a matter of choice. It's here and it's coming, and this will be more performed using the endorobots. Right now we are already doing it, and more endorobots will be there. And this is just a start. It's just gonna be not only probably even endoluminal, most likely also even transluminal through nodes that a lot of us tried to do that many years, but the technology did not support that. But that's gonna be a reality as well, through transluminal surgery or nodes, natural orifice surgery. I thank you all for your attention, and happy to take any of your questions if there are any.
Awesome. Thank you so much. So as far as questions, one is cost. What is the comparison of cost between doing this endoluminally and surgically?
Yeah, thank you very much. That's a very good question. We looked at that back in 2016, and at that time, I mainly were performing these in the operating room. Obviously, taking a patient to the operating room is more expensive. But even then, for left-sided lesions, there was a 37% cost reduction with endoscopic submucosal dissection or endoluminal approaches, treating same size polyps, same case match study versus colon resection. And on the right side, that was 43%. So right-sided are even cheaper, I think, to treat them surgically, or the vice versa. So there was a little bit difference between right and left, but either way, overall, the cost reduction was significant in both sides. And now, if I would repeat that study again, some of the easier polyps, we do them in the outpatient settings. I can tell you that would be even more significant, more pronounced, like the cost savings.
Cool. I imagine it's very patient and provider dependent, but what do you find as far as the number of people doing this in endoscopy versus in the OR?
So I think as surgeons, surgeon endoscopists, when you first start, I think it is safer to do them in the operating room because you're going to have more control. Like I indicated, if you run into problems, complications, perforations, you can just do laparoscopy and bail yourself out. And that's how I did for years, for 4 or 5 years. But during that time, there were no training courses, etc. Like nowadays, we have much, I think, easier learning curve for novice learners who are interested to get on this. But I think nowadays, like you can really quickly switch once you reach your comfort level to endoscopy. Having said that, there are still cases for me to date that I do in the OR, because I look at the colored images before I take care of these patients. And then complex lesions. I read very carefully the verbiage in the colonoscopy reports. Likely malignant. There's scarring in the center. I try to lift it and lift, or halfway they try to snare it, and then they couldn't. That's gonna be scarred. Probably may need full thickness resection, or there's high-grade dysplasia. High-grade dysplasia is a bad sign usually, more than the size. Benign lesions tend to grow bigger without creating high-grade dysplasia, but sometimes you get high-grade dysplasia in smaller lesions, and that's a red flag in my mind as well. Not all the high grades go to OR, but so you can make that determination. But something simple, like I look at it, a lot of colonoscopies, people are, screening colonoscopists are not, facile, and they are not willing to spend that extra time to do polypectomy, anything more than just 1.5, 2 centimeters large. And so not all of them really need to go to the OR. So you can make that determination based on your comfort level.
Mhm. And then what do you find the learning curve is for, say, you have junior faculty looking to get started?
The studies show that's around 40 and 50, and I tend to agree with that. The challenge is that different than Japan, we don't have a lot of gastric ESD, cases where it's easier to learn because I think the wall is thicker and perforation risk is much lower. But one advantage we have is we can learn these in the rectum, especially lesions that are posteriorly located or laterally located, so less risk for perforation. So that's a good way. But also depends on if, what courses you go to. And Dr. Larry Valen actually has a great learning tool that he really studied this in a lab setting, that there's a lot of practice units on explant material, organ tissues, and or tip control, making some, even writing some letters and so forth by using the tip with a little ink at the end. So you can really pass or shorten that learning curve with these type of techniques. I don't think we have any simulators quite yet for this, but that might be the next. But if we get to that point soon enough, and I know we will, with endo robots, I think that learning curve will be even shortened much, much more.
Makes sense. Well, we're just about 8 o'clock, so I think we'll wrap up. But thank you so much for your time. Fantastic presentation, and really great information. So we really appreciate it.
I appreciate that. Thank you for having me. Have a great rest of the night.
You as well. Take care.